Coming to the case scenario, Mr. J, 18-year-old gentleman, first year BD students from Vellore, presented with complaints of fever for 3 weeks. Coming to the history of presenting illness, patient was apparently normal before 10 days back, and then he developed fever associated with chills and rigor, intermittent and relieved after taking tablets. 5 days ago, he also noticed a swelling in the right upper neck region, which was insidious in onset. And he also gave a history of loss of weight 2 kg in the last 20 days from weight 64 to 62 kg. He also had loss of appetite since the illness, no complaint of sore throat, no complaint of cough with expectoration, no burning, ulceration, loose stool, joint pain, malar, rush, or any other complaints. Past history, he was hospitalized for dengue twice in 2019 and in 2011, otherwise no other comorbidities. Personal history, he consumed normal diet with normal bowel and bladder habits. So coming to the examination, patient was conscious oriented, recorded temperature in ward was 101 Fahrenheit, with the vitals were all stable. On examination, there was no pallor, icterus, sinuses, clubbing or pedal edema. There was an enlarged level 3 cervical node around 2 centimeter on the right side, which was mobile, firm in consistency, and no warmth and no tender was present. So systemic examinations were all irremarkable. There was no localizing finding. So differentials, coming to the syndrome complex of fever with lymphadenopathy for 3 weeks. Initially, we thought of tuberculosis. Given the age of 18 years, we thought of autoimmune disease, infectious mononucleosis, or HIV-associated lymphadenopathy, or malignancy, hematological malignancy we thought of. So we went ahead with the investigations. It showed HB of 14.4 with the WBC count of 3,800 with neutrophil of 47, lymphocyte of 38, and monocyte of 15. Platelets was 1,54,000. LFT creaturia was also on the normal side. Blood culture we sent to, it was negative. BBVS sent were also negative. Because there was a significant lymph node enlargement, we went ahead and biopsied. It showed expert TB, that was also negative. For the autoimmune workup, ANA, C3, C4, ESR, CRP, everything was on the normal range. EBV PCR we sent, which is awaited. Biopsy we went ahead and did. It showed necrotizing lymphadenitis on the right cervical node. Probable Kikuchi disease, lymphadenitis is a likely possibility. However, autoimmune connective tissue disorders have to be ruled out. We've already ruled out that ANA is negative and C3, ESR, C3, C4, ESR, and CRP is also normal, and there is no evidence of lymphoma. So our patient is diagnosed with Kikuchi disease. So I'll be talking about Kikuchi disease. Introduction, pathogenesis, diagnosis, whether it has a recurrence, and how to treat the Kikuchi disease. So coming to the Kikuchi-Fujimoto disease, it is described in 1972 by Dr. Kikuchi and Fujimoto in Japan. It is also known as histiocytic necrotizing lymphadenitis. It is a self-limited benign disease. It is usually seen in the age group of 20 to 30 years with the female predominance. It is in the ratio of 1:1.73. So coming to the definition per se, individuals with localized or generalized lymphadenopathy, confirmatory findings in biopsy and on histology in the absence of alternative diagnosis such as tuberculosis, lymphoma, or connective tissue diseases. So coming to the etiology and pathogenesis, so it is an immune-mediated response to an infectious or non-infectious trigger, and there is no genetic transmission or inheritance of a definite pattern has been identified so far. So the presentation in Kikuchi disease, the most common is lymphadenopathy. It is present in 100% of the cases. Fever could be present, rash is present in 10% of the cases, arthritis in 7%, fatigue in 7%, and hepatosplenomegaly in 3% of the cases. So this is a study done in the coastal South India. It included 47 patients diagnosed with Kikuchi disease based on the histopathological diagnosis. Here we can see the baseline characteristics showing this age group predominant in the 21 to 40 years of age. 44 patients were present, and rest all the age more than 40 were on the lower side, whereas in regarding to the sex, female sex were more commonly involved than the male. And occupation, there is not much difference. Presenting complaints wise, here we can see that the tender swelling over right side of the neck, and this is signifies there is cervical lymphadenopathy, and it's seen in 74.6%, and fever it is present in 52%. Rest all the presentations were on the lower side, hepatosplenomegaly, non-tender neck swelling, axillary lymph node enlargement, or associated cough. So presentation of the duration of the lymphadenopathy in 24 people, that is 35% of them, it is present in 0 to 15 days. In 47%, it is present in 15 to 2 months. 13%, it is 2 to 6 months. More than 6 months, it's only 3%. So our patient had a non-tender swelling in the neck associated with, it is present from 15 days, 21 days. So it is the most common presentation for the duration, whereas he didn't have any tenderness. So it's a rare presentation. So based on this study, they have concluded that the mean age of the presentation is 27 with a female predominance of 1.9:1 and the recurrence rate of 3 to 4%. So this is another study. It shows a presentation of the Kikuchi disease. How can they present? So here we can see that symptom-wise fever, joint pain, sore throat, headache, myalgia, all these can be present. Fever for more than 1 week is common. 77% is present. Whereas lymph node enlargement, this study also shows 100% people had lymph node enlargement. Other unilateral, bilateral cervical, both axillary or hepatosplenomegaly were comparatively were on the lower side. So coming to the lab investigations, they commonly had this anemia, and the next to it is leukopenia and leukocytosis, thrombocytopenia, and elevated C-reactive protein also present. They also had high erythrocyte sedimentation rate, high LDH, and high ALT and ANA positivity. So our patient had fever for more than 1 week and lymph node enlargement. And he had a leukopenia. Initially, it was 3,800, which gradually improved on repeat testing. So these are all the autoimmune disease case reports that are reported with Kikuchi. The commonly reported one is systemic lupus erythematosus, Sjogren syndrome, thyroiditis, transverse myelitis, and vasculitis. Why we have to search for it is because the Kikuchi disease in follow-up, they might present with autoimmune disease or they have the malignancy that can be diagnosed at a later time. So these are all the autoimmune diseases usually associated. The differentials to be ruled out before diagnosing as a Kikuchi Fujimoto disease are infection, autoimmune disease, and lymphomas. Infection in our patient, we've ruled out tuberculosis. We've also ruled out infectious mononucleosis, but EBV PCR is awaited. Autoimmune diseases, we've ruled out with ANA negativity. Histology wise, we've ruled out malignancy also. So there are 3 HPV features present in Kikuchis. Early one is a proliferative type, late one is a necrotizing type, and end phase is a xanthomatous type. Our patient had a necrotizing type, that is the commonest histological finding in the biopsy. So HPV difference between Kikuchi disease, SLE, and lymphoma also present. In SLE, the neutrophils will be present. In lymphoma, follicular hyperplasia, atypia. In Kikuchi disease, all 3 will be absent. So coming to the recurrence rate, it is mentioned as there are 3 to 7% cases going to recurrence. It is seen as common as 3 months and can present till 10 years. This is one study where the patient was diagnosed with Kikuchi disease and autoimmune hepatitis during her 3rd decade of life. And after 10 years of time, she presented with fever, rash, anorexia, and dark urine. At that time, also had a relapse of autoimmune hepatitis and diagnosed as Kikuchi disease itself. So even after 10 years, the people could have this relapse. So follow-up for such patients is also indicated. Usually follow-up is indicated for, there is no definite guidelines for follow-up for Kikuchi disease, but usually till 1 year the patients are followed, but they can relapse after 10 years and the follow-up for this Kikuchi disease should be kept in mind. This is another study that shows whether predictive factors can be seen for recurrence in Kikuchi disease. It is done in 1 or 2 patients. Out of them, 21 people had recurrence. Baseline characteristics and the investigations in the 1 or 2 patients were almost similar. The only difference that were make out in the tabular column showed that the patient who had recurrence had symptomatic duration that is more and had an extranodal involvement during the first presentation. So whether these 2 things can be used as a predictive factor for recurrence is not validated. It's just showing that they have more predilection for recurrence, but there is not much study to be added to it, and there are very few patients just to be followed up, and they are not usually used as a predictive factors for recurrence. So treatment-wise, there is no guidelines for management of the Kikuchi disease. In many patients, spontaneous resolution occurs in within 6 months. The treatment is only supportive. Steroids are usually given for Kikuchi disease. There is one study which shows us hydroxychloroquine has been used for Kikuchi disease, which showed improvement, but not much study has been done with hydroxychloroquine. With steroids itself, the patient usually recover. So learning point, Kikuchi disease presentation common is fever with lymphadenopathy. It is associated with infection, autoimmune disease and malignancy. Supportive treatment and steroids are the mainstay of treatment. Recurrence can till 10 years can also present. So necessity of follow-up should be kept in mind. Thank you.
Thank you. Nice presentation. Any comments, anyone? So here is, it's all based on that neck node biopsy. Yeah, the biopsy report did not show up, then you would be struggling with the diagnosis. So how does the pathologist know it's not TB?
There is
what makes it Kikuchi?
Granuloma formation is not there in the biopsy. And for the malignancy part, we've done immunohistochemistry also. There was a CD positivity that also ruled out this malignancy part.
But what makes it Kikuchi on the biopsy? With everything on the biopsy. Why do they say that?
It's just we have to rule out other conditions to diagnose this Kikuchi disease.
Okay. You mentioned it was necrotizing lymphadenitis here, but that's only one subtype you said. So it'd be nice to interact with the pathologist, know how, because without them we'll be struggling here. Yeah. So should you be routinely sending TB PCR for the lymph node biopsy? You do. Yeah. Should you be sending for culture as well?
Culture also we send.
You send that as well. Okay. Thank you.
Thank you.